I've been doing CAIRS in my practice for the last 2 years, and it's been a fantastic option for my keratoconic patients, where we've been able to improve their visual acuity dramatically. These are some of my happiest patients, and I look forward to my days when I have to do CAIRS. So it is a new frontier in corneal surgery. It's finally giving us an option to allow patients who have constantly been told no to PRK, no to LASIK. There are options that we can use to help improve your vision. So I have not yet gravitated towards manual, though I'm very tempted, I'm inspired, and maybe in the coming months I will. But so far we are doing femtosecond laser channels, partly because we already had one. We use intralaser to create our flaps for LASIK. So it was an easy transition to adapt this in our practice. So our typical depth is 250 microns, inner diameter of 4, and outer diameter of 7.5. And we're typically placing it in the steep location of the cone. The donor tissue that we get, it's typically the arc-shaped ring segments, and it ends up being about 50% of the corneal depth. So these are more of the parameters that you can use, and we program our IFS laser with these parameters, and I don't really change it too much between patients to patients, so this stays pretty static for all my patients. So first case, 61-year-old male. Most of his complaints are at night, many years of blurry vision. So this is an older gentleman. He's not your typical keratoconus age. His best corrected visual acuity, 2100. And so this is what his Galilei maps look like. And so you can see that there's a sagging cone quite apparent in the top left. So we decided to go ahead and perform CAIRS surgery. So let's see if this video will play. So the channels have already been created. I do have a video in a little bit which shows the creation of channels. So I actually create channels 360 degrees because it just gives me the flexibility of going whichever direction I'd like to go in. And using these specialized curved forceps, you just have to ergonomically maneuver them in. My drying method is I have not gotten the coffee warmer yet, but it is very tempting. I use a Mercell WEC, put the ring segments on it after I've washed it, and leave it out for about 20 minutes. And that works well. I typically do anywhere from 2 to 4 CAIRS procedures in a given day. So my technicians know that routine, so it allows me to do that. So now that it's in, I also use the corneal light reflex. It acts like a keratoscope, so it's so satisfying to have it go from kind of an oblong shape to a more circular shape once the segment is in the appropriate positioning. And kind of like snail tracks, it sometimes has a tendency to squish together. So I use the BSS cannula to just spread it out along its path to flatten it out even more. So you can see in the middle, the circle light, the keratoscope appears nice and circular. So it's very satisfying to achieve that. So here's another, so this is post-operative. So you can see quite a significant flattening has occurred in that cone. And here's a difference map. So post-operative on the left, pre-operative in the middle. You can see all the flattening. In some areas, it's as much as almost 7 diopters. So overall, flattening was at least 4 diopters. So very, very good outcome from this procedure. So I've played around with other tissues. So this is Natural. So Lion's Vision Gift uses this. So you can see in this video the femto channels are being created along with the incision. And then I use a little dissector to create that opening. And once that's done, I have this little dissector that I use to just reopen those channels that have been created by the laser. And I do it bidirectionally because it allows me the flexibility that if I need to, for any reason, pull it from the other end, I'm able to do so, as I'll showcase in this particular video. So once this is done, time for the tissue. So I use a little Siddiqui instrument to help lift up the edge of the corneal tissue and just kind of push it in to get the insertion started. And you can tell this particular tissue, you could argue, could have been dried a little bit more. It's a little bit wet. Certainly, more recently, I've been drying them out for a little bit longer. So, but it goes in pretty smoothly. And once it's in, you can see these. I'm using these curved forceps to do that. So, in order to get the curved forceps out, now I have to use the Siddiqui to just hold the tissue in place as I'm trying to retrieve my forcep out. So this was probably case number 4 or 5, so still pretty early in my doing of this procedure. So using the Siddiqui again, just pushing it forward, and it just glides beautifully forward. And then, so here in this case, I actually go through the other end to try to sort of grab and almost hook it and bring it right where I want it to be. So almost going underneath it and then just hooking it up and then sliding it to where it needs to be. And now using the BSS cannula to just spreading it out and just getting it to flatten out even more. So this particular patient, that's pre-op on the left, post-op in the middle. It's quite a significant bit of flattening here, almost 7 diopters worth. So here's another case, 38-year-old male, best corrected acuity of 2100, and you can see that there's a cone that we're gonna simply try to flatten out. So that is post-op right there. Here's another case, pre-op of 2080, and you can see that 2 months post-op, placing the ring segment inferiorly had a significant effect in their overall corneal shape. So 8 months, so this particular patient, 8-month post-op, 20/25 visual acuity, quite a significant drop in their astigmatism from 6 diopters to -175. So we actually did a quick in-house study looking at topographic reduction. So we had a average reduction, so in a sample of about 60 patients, an average reduction of 3.45 diopters, manifest cylinder reduction of about 2.5. Our uncorrected visual acuity improved about 9 letters. And best corrected even more, 14 letters. So 49 out of the 57 patients, the thickness that we used was 508. So that's typically the tissue that we get. And most of these patients were successfully fitted into contact lenses. And some even went on to get ICL surgery done to treat their residual refractive error. And one continued to have cataract surgery, had toric lens. So future is exciting. Being a fan of AI, I do think AI has to play a role in this at some point. So AI-based nomograms could allow much better customization of these patients and give us better outcomes. And maybe we can take a more stepwise approach, in terms of when do we do the cross-linking? Do we do it at the same time? Do we do it 3 months later? And so we're still, I guess, we're still trying to figure out what the best treatment paradigm is. But it is an exciting step forward in tissue-based biomechanics modulation. So that's it from me. Thank you so much.